It's Patrick Hutzel from intensivecarehotline.com with another quick tip for families in intensive care. I should say with another tip. I'm not sure whether it'll be a quick one today because I'm going through a question from a client that, and it'll be probably very detailed. So the client has their father in LTAC at the moment. So this is one of our US-based clients who has their father in LTAC with the tracheostomy at the moment. And the LTAC is very reluctant to remove the tracheostomy. And, with what we are seeing here, we believe the tracheostomy can be removed, but they're adamant that it can't. So let's just go through a few things through the question today so that you can understand and feel empowered when you have a loved one in intensive care or in LTAC, so that you can make informed decisions, have control, power, and influence as well. So I was on a consulting call with this client a few days ago, and the LTAC is telling our client that her father still can't have the tracheostomy removed because he has too many secretions and he apparently aspirates secretions into his lungs, making him vulnerable and could expose him to chest infections. But let's just go through the questions one by one, and then we will dive really deep into this whole topic. So first question that she has is, why does my dad have so many secretions? Now look, there could be a number of reasons when someone has a tracheostomy why they have so many secretions. It could be, fluid overload. I know that this particular gentleman was on mucomist, so, that would loosen up secretions. So that could be one of the reasons. The next reason could be he's potentially fluid overloaded. Got to look at fluid balance. If all of a sudden someone in intensive care or in LTAC is 3 liters positive every day, which means, there's, 5 liters going in and 2 liters going out. I'm exaggerating here, but you get my point. Then all of a sudden you could have increased sputum production. Now, other reasons why someone might have so many secretions is actually, if you suction too often, there is more sputum production because, coughing gets stimulated and so forth. Now, other reasons why someone can have increased secretions is, for example, the usage of a speaking valve. I've seen that when someone is using a speaking valve, they might produce more secretions. They might also produce more secretions when the cuff is down because it can irritate the tracheostomy, and again, the irritation in the trachea might make a patient produce more secretion. So those are some of the reasons why your dad might have plenty of secretions. Now, next question that she has is, what is considered too much suctioning? And she also says there's blood from, or is there blood from over suctioning? Look, for someone in intensive care or in LTAC, or even with our home care clients with intensive care at home, we suction them when it's needed, which could be anywhere from every 5 minutes to every 5 hours and anything in between. It could also be once a shift. It really depends on, how much sputum production there is. It also depends on whether your dad can clear his own airway, but I believe we come to that in a minute. So too much suctioning is anything, I argue, that could distress a patient. If you're constantly suctioning, it would probably also decrease the oxygen saturation for a patient, could decrease the oxygen saturation for your dad, and then he might need to go back on a ventilator. So that would be considered over suctioning. But then, and if there's blood from over suctioning, yes, because you're causing trauma, that would potentially be considered over suctioning. Next question is, how to minimize secretions or thin them out? Mucomist for weeks now, limited therapy and mobilization that will not increase at this particular LTAC facility. Well, first thing is, not surprised about limited therapy and limited mobilization. I mean, I've done countless videos about that LTACs are not equipped to look after intensive care patients or patients with a ventilator with a tracheostomy. It just confirms my point. So how to minimize secretions or thin them out? So one way to minimize secretions is simply by using a medication such as glycopyrrolate. And another way to minimize secretions is by, again, looking at fluid balance. Would a fluid restriction potentially help, to not go into pulmonary edema all the time? Another opportunity or another reason why there could be increased production in suctioning is there right heart failure? Is there heart failure? Because then the heart can't pump all fluids around, and then it could push back into the lungs, and then you've got, again, increased secretions. Number 4, what humidity should be used on the tracheostomy collar? 5 to 6 liters per minute, right? Aren't they creating more secretions when the humidity is too high? Now, that is actually a great question. I also think that's a little bit of a myth for families in intensive care. So there should definitely be humidity when someone is on a tracheostomy without a ventilator, right? So when someone is ventilated, they should be ventilated via the tracheostomy or with the breathing tube. The temperature should be 37 degrees Celsius, which is around 100 Fahrenheit. When someone is on the trach collar, the temperature should be around 32 degrees Celsius, which is, I don't know, probably somewhere around 1995 Fahrenheit. Maybe someone can type that below this video. Should it be on 5 to 6 liters per minute? Not necessarily. It could be just 1 liter per minute. It could just be a minimal flow, but the humidification needs to be there. Why does the humidification need to be there? When you're breathing in through your nose, like this, air automatically gets humidified through the nose, right? And it's at 37 degrees, generally speaking, because when someone is breathing via a tracheostomy, the air needs to be humidified and heated, right? Because there's no natural filter and no natural heating when someone breathes in through the tracheostomy. Now, that also leads me to that when the trach collar isn't used, then a Swedish nose or an HME filter can be used. I'm not going into too much detail there today because I want to get through all questions. Next question, number 5, how to get secretions past a trach tube. They will not use a smaller cannula. Great. Great question. Well, they should, once again, make him cough, give him cough, do some coughing exercises with your dad, but when we were talking on the phone, and I'm not going to identify you, of course, but when we spoke on the phone, you actually said that your dad had a really good cough, had a really good strong cough. So I'm not sure why they can't remove the tracheostomy, so they should downsize the tracheostomy. I think he's got a size 6. Maybe they can take it down to a size 5. But if anything, they should remove it, really, Then the next question you have is, what is the standard practice for weaning off the trach collar? Well, the trach collar will actually stay until the trach will be removed, because once again, just as I explained a minute ago, the trach collar is not there to help breathing, really. The trach collar is there to help humidify and warm the air. That's the purpose, really, of a trach collar. And if you're not using the trach collar, secretions will dry up, and then there's the risk of sputum plug, So, and okay, let's just say someone is down to room air, 21% of oxygen, and they have a small sized cannula. They're having minimal secretions, right? They can swallow, right? They can swallow, they can talk when the cough is down, and then the tracheostomy will be capped, which means it will be blocked with a plug, and then with a plastic plug, not with the sputum plug. And then if your dad can breathe, he's got a good strong cough, can obey commands, can swallow, the tube can come out. So it's not so much a case of weaning the trach collar, it's about removing the tracheostomy when your dad is ready. Next question, will you always find secretions when you suction? No, not always. It really depends. Really depends. Question number 8. What if they're right and he's aspirating? How to stop aspiration? Just therapy? No. The way to stop aspirating is to put the cuff up on the tracheostomy, right? To put the balloon up on the tracheostomy. That will stop aspiration. But as we discussed on our call, your dad is not aspirating. Chest X-ray was clear, even though the cuff is down. So there's a very high chance he actually can swallow. But again, the way to stop it is to put the balloon up on the tracheostomy and block it. Number 9, can aspiration really cause 20 plus white cell count with hypotension but minimal chest X-ray findings, no sputum culture growth? They are doing serial sputum samples every 2 days and none are growing anything and no need for increase in oxygen. I would argue that an aspiration pneumonia can absolutely cause 20 plus white cell count with hypotension, but not with minimal chest X-ray findings. I argue if your dad has white cell count of 20 plus hypotension, he might have a UTI or he might have a sepsis, a bloodstream infection. The infection, I argue, would be somewhere else. Next question. Does tracheomalacia make it hard to swallow? It may not necessarily make it hard to swallow, but the risk that the airway is collapsing is higher, right? And then again, you probably have the risk of aspiration or again, a block. Number 11, are there treatments for tracheomalacia besides tracheostomy and stenting? Not that I'm aware of. Not that I'm aware of. Those are the 2 options from what I understand. Number 12, how to convince doctors to look elsewhere for cause of fevers and leukocytosis despite multiple refusals already. We convinced one doctor to do an MRI of wounds for osteomyelitis and a flow cytometry test. But I fear if those come back clear, he will stop looking like everyone else has. Well, I can tell you what, if there's an unknown cause for fever or leukocytosis and you've had multiple refusals, but you can see something's not right, there's a number of things that I would do. The first thing that I would do is I would jump ship and leave the LTAC as quickly as possible, get him back to ICU. Once again, I've done countless videos around why no one should go to LTAC ever from ICU anyway. So I would jump ship and try and get him back to a hospital, and we can help you with that. And the next thing that I would do, if for whatever reason that's not possible, write to hospital management, try to, sort it out on the LTAC level. But if that's not working, you got to talk to hospital management. So I hope that helps and answers all your questions. Now, and another thing that I would do is, if your dad can't have the trach removed, but it doesn't look like, to me, like it looks like he's ready for that, but if he can't have the trach removed, as a next step, look at services such as intensivecareathome.com. Go to our sister site, Intensive Care at Home. We are providing a genuine alternative to a long-term stay in intensive care. With Intensive Care at Home, no need to go to LTAC. We are currently operating all around Australia in all major capital cities, including all regional and rural areas. And we can help your loved one to go home from ICU as well. We are NDIS, TAC, NIISQ, iCare, and DVA approved service provider. But we have also received funding through the Department of Health. So you should absolutely contact us. Also, if you're an NDIS support coordinator, we are specialized on tracheostomy, ventilation at home, home TPN, home infusions, BiPAP, CPAP ventilation, and so forth. Anyway, coming back, and if you have a loved one in intensive care and you need consulting and advocacy, please contact us at intensivecarehotline.com. Call us on one of the numbers on the top of our website, or simply send us an email to support@intensivecarehotline.com with your questions. Also, have a look at our membership for families in intensive care at intensivecaresupport.org. There you have access to me and my team 24 hours a day in a membership area and via email, and we answer all questions intensive care related. We also provide medical record reviews in real time and a second opinion in real time. And I also talk to doctors and nurses directly. I can represent you in a family meeting with the doctors and nurses with intensive care teams. and I can certainly and have put stops to patients going to LTAC unnecessarily. You can already see it's a disaster area. We also provide medical record reviews after intensive care if you're having unanswered questions, if you need closure, or if you are simply suspecting medical negligence. Now, thank you so much for watching. Subscribe to my YouTube channel for regular updates for families in intensive care. Click the like button, click the notification bell, share the video with your friends and families, and comment below what you want to see next or what questions and insights you have from this video. Thank you so much for watching. This is Patrick Hutzel from intensivecarehotline.com and intensivecareathome.com, and I'll talk to you in a few days. Take care for now.